Good morning. Welcome to the next installment of the Treat Live program, our monthly live cases brought to you from Mount Sinai. I'm Jay Varvamurthy, one of the IR attendings. I'll be moderating for you today. And today I'm graciously joined by Sandeep Bagla from the DC area.
Thank you so much for having us, Jay. Looking forward to seeing this.
We'll go over to the lab right now where we have Dr. Fischman, who has a patient with knee pain.
Well, good morning and welcome to Mount Sinai. This is our September version of Treat Live. We have a very interesting case for everyone today. I think there's a lot to discuss here, so we are gonna get right to it. To my left is Dr. Garcia-Reyes.
Good morning.
And our PGY6 resident, Simon Chivi, and our PGY4 resident, Chloe Cross. So with that, I'm gonna pass it over to Simon. He's gonna present the case for everybody.
Morning, everyone. We're presenting a case of genicular artery embolization for left knee osteoarthritis. So this is a 61-year-old female with a past medical history of osteoarthritis. She has no other relevant past medical history. Her baseline pain in clinic was about 3 out of 10, but it gets up to 8 to 9 out of 10 when severe, and it's progressively worsened since her clinic visit a month or two ago. Standing and getting up from a car seat have been particularly painful, and she endorses stiffness after being seated and avoids sitting in a low seating position such as a couch or a car seat. She occasionally wakes up at night from pain but struggles to get out of bed, and acetaminophen helps occasionally. She has a relevant past surgical history of bilateral knee arthroscopy, 2009 and in 1995, but both provided minimal relief. Over the past several months, her pain's gotten progressively worse, and she saw an orthopedic surgeon. She then had steroid injections a few months ago, but they also provided minimal relief, and she was started on a weight loss program with metformin. Based on her exam and imaging findings, a total knee replacement was recommended. However, the patient is taking care of her mother with Parkinson's at home and doesn't feel comfortable recovering and being unable to care for her. So she desires a minimally invasive option to get her through until she can find time to recover from a knee replacement. On pre-procedure exam, she had patellofemoral pain with axial loading. She had patellofemoral crepitus, lateral joint line tenderness, and a small effusion. Her labs are unremarkable. Based on imaging, she has stage 4 arthritis on the Kellengren and Lawrence classification scheme. She has joint space narrowing, subchondral sclerosis, osteophytic lipping, and cyst formation. And she has valgus deformity of the knee. Left is worse than the right, based on increased tibiofemoral angle. Her pre-procedure MRI is shown here, and it shows advanced lateral compartment, predominantly tricompartmental, with patchy subchondral marrow edema in the lateral compartment, degenerative tearing of both the menisci, left greater than right, lateral greater than medial, and a large joint effusion with synovitis and fatty synovial metaplasia. So assessment and plan, this is a 61-year-old female who's 5'5", with history of osteoarthritis with severe symptoms. On the left with a WOMAC score of 51 and a visual analog scale of 6 out of 10, up from 3 out of 10 during the initial consult. Pre-procedure MRI, again, demonstrates joint effusion, left greater than right cartilage loss, joint space narrowing, and bone marrow edema. Her visual analog scale the day prior to the procedure, again, was 6 out of 10. WOMAC score was 51, which puts her at 53%. And the plan for today is left genicular artery embolization. And we're here with radial access and have femoral access as an option, but think we can do this radial. We'll follow her up in clinic and see what our options are. The equipment, we have a 119 centimeter radial to peripheral sheath, 150 centimeter glide cath, 165 centimeter lambda microcatheter, glide wire advantage, and some Hydropearl 200 micron microspheres.
Okay, well, thank you, Simon, for that. This is, again, an interesting case in the sense that we were talking a little bit about the access site, and there's obviously lots of options that we have for access for GAE. And so I'm very curious to hear from Dr. Bagla how he prefers to access these cases, because I know it's probably not radial access, um, for a variety of reasons. And I think there's a lot to discuss. I think one of the interesting parts about this procedure is that we are not optimized yet for radial access. We are better than we were years ago, but the equipment that we're using today is the best that we have. But there are limitations, and we're going to demonstrate some of that, some of the advantages and disadvantages. But before we talk, I want to show you guys what we've done so far. If we just focus a little bit on the wrist over here, I'll just show everyone what we have. We have this is a 6 French R2P glide sheath slender. So this is 119 centimeters. It allows us access into the SFA, actually. And so we have this down into the SFA. We advanced this after we had access over a glide wire advantage, which works really well. And then through that, we have a hubbed 150 centimeter glide cath, which is one of the longest diagnostic catheters that we have. And so we have a few options now left for our microcatheter. We are going to start with 165 centimeter triple angle lambda microcatheter, which allows us more distal access. We'll load that with a fathom wire. And we've already done a couple angiograms here. So with that, I'm going to ask you guys to comment on number one, the case, but then also the access site and what you guys prefer over, down in Virginia and elsewhere, Sonny.
Hey, thanks, Aaron, and thanks to the team for having us participate. You know, I'm a kind of simple guy, Aaron, and pedal has less letters than radial. So
Yeah,
we tend to go pedal. I think the advantage obviously is the closer length, not having to worry about things. There are issues, obviously. I think dragging a catheter from a pedal access site down through femoral when it has to have a fairly acute angle can be a little bit, nerve-wracking in certain cases. But I'd say overall, let's say 90% of our cases are pedal, about 10% of them are transfemoral. And we've yet to be successful with a radial case. So this will be great to see you do this, and I'll be learning a lot too from this.
we always have the option to switch to femoral, and we may actually end up doing that if we can't get all the vessels that we want. But I think we have a lot of equipment here that's going to allow us to complete the case. Pedal is a great option. I think we don't have a lot of experience doing pedal for this procedure here, but it definitely doesn't limit us in terms of the equipment selection. We have lots of different equipment that we could use for pedal as compared to radial, as you'll see in a few minutes. I wanted to show you guys a couple things. So here we have on the image, that's our sheath sort of hub. This is 119 centimeters. And so I was optimistic that we would be able to get the glide cath into the pop, but I really just got it just to the distal SFA, looks like almost to the pop, which you can see on the next image here. This was the first run that we did through our sheath, and so we'll talk a little bit about the anatomy here in a second, but we definitely see a fair amount of hypervascularity off of several of these genicular arteries. And then we did a more zoomed in run with our base catheter, and you can see on this image here exactly where that catheter is hubbed. And then we can see a couple different targets. So what does everybody think in terms of the first target we should go after? Let's grab the microcatheter. We'll start working while we're talking.
Aaron, I think it's always nice in these cases to work proximal to distal. As you know, after you embolize one vessel, oftentimes you'll get retrograde flow from another vessel into the same territory. It just makes it pretty straightforward. That being said, of course, if you pass that, I assume you're targeting the lateral branches, right? Superior lateral, inferior lateral, and the recurrent based on her symptoms.
Yeah, that recurrent off the tibial looks like it's a target as well. One of the things that I was thinking of maybe to target that one first. I also want to show you guys the tip of this catheter. Let's pull the wire back so you guys can see this. Let's see. Here we go. So this is the 165 triple angle 1.9 French. This was actually purpose-built. This is a ProGrade Lambda. This was purpose-built for prostate embolization, but we're going to use it here today. I think this is going to be actually a good catheter for that distal branch, and it may reach, it may not. We'll find out in a sec.
Yeah, Aaron, do you guys have a limit, or Jay, was that for me?
I don't have a limit. Do you have a limit, Sonny?
I would say with permanent embolic, I tend to limit it to 3. I make an exception for 4 in a significant hemarthrosis case, just because of the amount of postoperative pain. that a patient will have, and potentially even a cutaneous complication. But I would say 3 is a good number. Here, I was going to ask you guys, because she has lateral pain, but also I noticed she had some peripatellar pain. If you're going to focus it all on a suprapatellar branch, which can come from the DGA, and it'll probably be a much easier branch to get into. It'll be a little more proximal, but I didn't know how much of her pain was palpable there, or it's primarily palpable on the lateral aspect.
Most of her pain's here on the lateral side, and so
Yeah.
this is actually pretty interesting. We are basically hubbed at the distal. I think we could probably get into this. Sometimes if you push the catheter without the wire, it'll go. But this is 165, and we still have an option for the 175, which we also have. But I wanted to just show that really quickly, that I think we can probably navigate distally into that branch. Not exactly what you ideally want in every case, but here you can see that we have a little bit of a length issue on this distal vessel, but we might be able to potentially embolize from here with the 165. But I think probably what I'm going to do first, as you mentioned, Sonny, is to just pull back and do this more proximal one. This looks like the middle genicular artery. You agree?
It might be the inferior lateral. It's hard to tell.
Yeah,
I'd
let's
pull
take
back
a look.
little. Yeah, I'd pull back in doing this run, just because it might be in a branch going down as opposed to just straight lateral. There we go. Yeah. Aaron, just so I can understand, on the back with your micro going through the base catheter, what do you guys have? A flow switch or a Y adapter, a TUI Bors? What do you guys have?
No, we're not using any TUI here.
So you just go, you
one of
float the micro.
Yeah, I don't really like TUIs anymore. Maybe it's because I'm a radialist, but I don't use them for prostate embolization. I haven't for a long time. I also like to be able to just move the catheter freely and not have to worry about it. It doesn't seem to be moving too much. What do you guys think of this angio? Because we're in this, like you said, I think this is the inferior lateral geniculate. You agree?
I think so. Do you have your pre-run real quick? But I think that's it. And then you have a little bit of cutaneous lateral.
I thought initially on that first run that some of those branches that were sort of along the lateral joint compartment were very hypervascular on that image. You can see that right there.
I think that is, so that looks like the inferior lateral. Initially, it might have been going in that branch going down. I think that's a great spot. There is a little cutaneous out laterally supply on your run. If you can play that run
Can we
again,
get some nitroglycerin, please? Yeah, we're going to give a little nitro. As you know, nitro is our friend with regard to all these small vessels. Do you routinely give nitro when you do these cases in these vessels?
Yeah, we routinely give about 100, 200 mics before administration of the embolic.
Yeah, and I think that's a good tip for any embolization that you're in a small vessel. We don't do it as much in the liver when we do TACE and Y90. But I feel like it's probably underutilized, particularly in small Y90 cases. I think it probably makes sense to give more nitro than we give. But we always give a lot of vasodilators in prostate embolization, as you know. So let's get 1,000. We'll just have it. We're not going to use all of it.
Karina,
okay, so
you guys going to go past that branch, past that inferior branch, and maybe go a little further out lateral?
Yeah, we're gonna probably go a little bit further. So Kirema's gonna grab the wire. I have a Fathom 14 wire.
Do you have space with the
Yeah,
micro?
we got another inch or so on the microcatheter. So I'm happy with the way that the 165 lays out here. I think given that she's 5'5", that's reasonable. If somebody's gonna be even 5'8", I think we're gonna have a lot of length issues with something like this, right? So this is sort of the limit of what we can probably accomplish from a radial approach.
Correct.
I think. We went up a little bit higher on the arm. We probably could have gone even a little bit higher than that. But the vessel got very deep and small. And so you have to obviously weigh the risk and benefit of going more distal. This catheter is awesome, by the way. It's we're going to just see what it looks like over here.
Now we're hubbed, right?
Yeah.
Here.
It's got this triple angle. It's very small. Tracks really nicely. I like this a lot for type 1 origin prostate arteries. It's my favorite shape in this particular model or brand. Let's see what this looks like.
I need more. One more, yeah.
So we do have those cutaneous branches, but I think we see a fair amount of hypervascularity here. Would you guys agree?
I think that's
Definitely
great.
see that blush, yeah.
I agree. It
And
looks good.
Yeah.
We got.
You see a
Let's
little
put
bit of
some
arterial
nitro in.
branch.
Okay, you only
Yeah,
have
shunting
3
as
right now.
well, which you'll sometimes see when you're this selective, which is nice to see that early shunting. And
Yeah, you see that for sure. That's a good sign, right?
Giving it right now.
All right, so
It
I
is,
just
and
gave 150 of nitro. We're going to take one more picture after the nitro because things do change after nitroglycerin. And we're going to zoom in a little bit.
What's your embolic of choice?
yeah, so it's about 200 micron is probably a good
Why not zoom in, right?
safe embolic, I would say, in somebody who's just got osteoarthritic related pain. So we'll typically use 200 Hydropearl. Occasionally we'll use 100
lot of
Embolization
shunting, right?
to have more of an earlier stage arthritis, so they don't have as much hypervascularity as this. But this is, I think this is a perfect spot. In fact, the wire that was going out, subtly there's a branch going across the joint line to the medial side, and this will have an arcade that occasionally will go all the way over to the medial side. But this is a great spot to embolize from. I think you guys will get a good result here.
Yeah, I
And
think
when
we're
you
going
guys
to, I mean, we're
embolize-
probably not going to be able to avoid some of that cutaneous stuff. What do you think? Should we put an ice pack or just let it be?
I'd let it be. I just,
Yeah.
I would let it be too.
Okay. Let's check.
I like
Go ahead.
I like Kirema's choice
Sure.
too. Yeah. Yeah, I think,
To be
Aaron,
fair, I've
here's
never
the thing. The delicate nature of just the embolization is, I think, what determines the degree of skin related issues. As long as the patients understand that's just transient skin discoloration, they should be fine.
We have 200 micron. Here, I'll 200 micron. We already mixed these with contrast.
Aaron, what's our dead space in this lambda?
The dead space is at least a half
Yeah.
yeah, it's a lot of dead space because it's a long catheter. I think it's like 0.5 or 0.6 to be honest.
We're all ready.
We're gonna go real slow here because it's a tiny vessel. How much do you usually put in here?
I think we have enough
In
in there.
something like
This is
this,
another-
I'd expect to put in like 0.8 to 1.2 maybe.
Yeah.
I
Yeah,
do
we
adjust
have enough.
a little
we're-
bit based on what the other target vessels might look like and what they would accommodate. But I'll give it in 0.4 aliquots. I'll just give it till I just see it and then flush it through slowly. And then just do an intermittent run just very lightly to see what it looks like. And at that point, I haven't overcommitted.
We're
Yeah.
pushing really slowly. and
We're
we
going real
already
slow
have-
here. I mean, there's not a lot of room here for it. I mean, these are not
Yeah.
these are not tumor embolizations, so you're not gonna get close to the amount of embolic that you're gonna use in other vascular beds.
Hey, Aaron, did she have pain during your injection at all, or report any warmth in the area of where you guys did your
No,
injection?
she's pretty asleep actually. So
Okay,
I don't
okay.
know that I could.
Is that something you usually see,
She's taking a nap.
Sonny?
Yeah.
Yeah, typically we do. I would say it's not all the time, but
That looks
certainly
pretty
they'll
good. Here's
report
saline.
That's it.
either a very hot feeling just from the contrast or a pain that's similar to their pain that they normally have. And that can be reassuring. Oftentimes they'll report it either during the diagnostic portion or during treatment.
So that was about a cc and a half.
No, I don't know. I've been flushing for a
But the
while.
dead space we have to subtract. So it's
Exactly.
about a cc,
Yeah.
full cc of very dilute particles. I think we're probably done with this vessel. We're just trying to get this to flush. So let's go back and look. Can you guys see the angio or you can just see the live fluoro?
Live flow.
Live flow.
Okay, I wanted to go back to the initial angio.
There, now we see it. We see a 5 French run.
They put,
All right, I'm going to go through that real quick and we'll just take a look at what we think the next target should be. Let's just let that clear for a sec. So we're definitely going to interrogate the recurrent artery off of the anterior tibial. We may do that later. What about the superior geniculates? What do you guys think here?
Yeah, I would target that superior lateral genicular, and
Yeah,
it probably just has that
genicular.
180, yeah, 180 reverse curve. There's two branches coming off right, kind of overlapping. I'd say it's not the one
Yeah.
that's coming off 90 degrees. It's probably the one that's draping over the lateral femoral condyle. So it's coming up and then down.
Going cranial and then caudal. I agree.
You got it.
Yeah, so we're gonna maybe do we might do a different view.
Let me
In
just
terms of
start
other
with-
vessels, I think those are the three that we're gonna work on. Do you think any of the medial vessels make sense at this point? I think maybe that superior medial we could target, but the one on the lateral compartment is much bigger, clearly.
Yeah. And I think if you have somebody who's got primary peripatellar or patellofemoral arthritis, and that's their pain, then in that situation, I would target DGA in both superiors. But in someone like this who's just got lateral side predominant pain, I would do the 3 laterals.
Yeah, that's what we were thinking initially. So we
I'm
could take the
impressed.
microcatheter out completely, or we could do a final run through here. But it looks like we have to clear it a little bit more.
Yeah.
And we'll take a quick look and we'll see. I think we're done with this vessel.
Aaron,
Yeah.
I was fairly impressed with how you guys floated that curved microcatheter into this vessel.
Yeah.
Knowing
yeah.
little torqueability we have, even when we go up and over sometimes to get into these genicular arteries. So in this situation, let's say the catheter was fully flush. Could you just try and float that catheter because of its curve, at least to the ostium of the superior lateral? Okay.
Yeah, you could. One of the things that I like about these curved catheters, particularly this one, the Lambda, and then also the True Select, is that they are very torqueable. But really, you need to have the angle on them. I tend to use a Fathom 16. This one, we're using a 14 just because it's such a small catheter. But with the 2.0 catheters, the 16 is fine, no issue.
Okay.
But yeah, I mean, torquing it into the vessel is one of the best things about these catheters, and they really perform really well. They really changed the game in terms of microcatheter work. We've had a lot of experience with both of them, and they're both excellent. Okay.
Sonny, while we're flushing this, can you talk a little bit? What are you using for your pedal access?
Yeah, tell us a little bit
Yeah.
about your pedal setup.
So we'll use 4 or 5 French access, DP preferred. However, we will use the PT occasionally. Vessel size has to be 1.5 millimeters, I'd say, outer to outer. We will primarily go up. Our base catheter of choice will either be a NAV3 or a Dave catheter. So a little bit of a hook on it that doesn't have much of a width. So it's an acute hook, but the width of the hook is about 4 millimeters. So from the vertical axis to the horizontal, it's about 4 millimeters. And so it doesn't really scrape along the popliteal artery or femoral artery. That's probably our base cath. Either of those are our base cath of choice. 65 or 80 centimeters. We'll use a 2.4 microcatheter because we're primarily directing the base in that situation, either towards the origin or
Correct.
away. And then I would say the only other niche catheter we use is called the Hastings U-turn. So it has a complete U-turn on the catheter. And that allows you to basically make essentially a Waltman loop in the femoral artery with your microcatheter. So that tends to be nice. And it also stays off the wall, which is nice. So those are the 3, Dave, NAV3, and a Hastings is the 3 catheters we use.
Are you going up and over, or are you going ipsilateral?
Yeah, we're typically, when we go femoral, up and over. And we'll typically use a 70 sheath and then just work through a 70 sheath. Some of our docs work with a base catheter. I tend to try not with a 70 sheath just because it's at the level of the DGA as well.
I think the one thing we were hoping here that we actually didn't get was to be able to select with the base because we were a little short.
Yeah, so one of the best things about doing these cases is being able to use the base catheter to select these really angulated vessels. So one of the limitations, and I think we can see that very clearly, particularly with this vessel, is that we're not going to be able to use the base catheter to help us select it. I'm just going to try to find a different view here that's going to give us a better angle, and then we'll put the microcatheter back in. I think it's maybe the other way.
Yeah, that's great.
Correct.
Right there, Aaron. Like you guys are
You think
doing
this?
that.
You think this?
More?
Let's see.
I think you guys got
Yeah, there we go.
Yeah.
it. Yeah.
I think we see it pretty well there, right? You guys see that?
Yeah,
So
that's
too.
That's about as good as I ever
The
see
gen-
it. That's great. Yeah.
The genicular arteries that are large are typically the ones that are causing the issue. Would you agree with that, Sonny?
Yeah, I'd agree. And they tend to hypertrophy or be larger if maybe another at the same side is not as big. But you guys did this great because everything on the right
All right,
side
Simon,
of the
let's
screen
bring that in.
is anterior and everything on the left side of the screen is posterior. So all the branches on the left are feeding the calf muscles, and all the branches on the right are feeding the synovium and going towards the patellar anterior aspect of the knee. So that's a really great run that you guys have. And actually, there's a small little branch, Aaron, if you guys can see it, just under the, just at the origin near the superior lateral. And that's the middle genicular artery. Yeah, that
That's
little
the middle
tiny one.
geniculate, right? Yeah.
Yeah, it's a great picture of it you guys got. So
It comes
and I
right.
actually
Sometimes
like
it
where
has a shared origin.
yeah, I like where your base is. I think you guys will get this. I think actually being
Yeah.
off the opposite wall.
All right, who wants to
I think
use
you
the
got
wire here?
I got
really
you.
well.
Gonna go right in.
I think we want to go in the one above. No.
This wire's a little fatigued. I actually like the 016 wire a lot better than the 014 wire. I really have a distaste for 014 wires, and that's just my personal preference. So one of the things that we can do,
You can just bring it distal
is-
and bring it back and just hook it. Yeah.
Correct.
Yeah,
Here, I think
Looks
you
like it wants to
might-
go.
Yeah.
it does.
Yeah. So while you guys are doing this, do you guys ever find that after you get the wire in, it's hard to pass certain varieties of shaped microcatheters? Some of them are so stiff that at the curve where you get the wire in, and then do you ever find that it's difficult then to pass the micro? And it
Yeah,
herniates.
but that's
Yeah.
another reason why I use the 016 and not the 014.
Okay, that's a good. Yeah.
We're close. We're just not getting it yet.
Oh yeah.
Change
I'm
over.
actually moving the catheter more than Dr.
wire,
Garcia
yeah.
likes.
That and so one
We
person
usually
dropped
don't do
here.
cases together.
I
I'm
think
more of
she's
a-
leaning-
I'm gonna grab a different
I'm
wire.
more of a shape your wire, not your catheter kind of gal.
Can I try 016 Fathom? I just want to see if it's hubbed. So, the 016 Fathom comes in 180 and 200, and I think also 215. I think one of them is back ordered today, so we're gonna see if we can get the 180.
Change this curve.
And then can I also get the other wire that I like, that I use all the time on the prostate side, is the 016 Meister wire, which I think you told me about that, Sonny, years ago.
I think that's
I
our
know you like
go-to
that wire as well.
Yeah, it's our go-to wire for cases because it has a nice amount of support. And actually, if Kirema's doing what I was thinking exactly, is I was going to ask that question. How does it look when you puff
Oh,
through the micro?
we're in that other branch.
And
Yeah, we're in the other branch. Yeah,
and
we gotta,
so
we're in
so-
that branch, and so it must originate a little bit higher.
Yep.
Yeah,
That's why you got me,
Yeah.
Aaron.
yeah.
and I think
That's why we got her.
We're changing this to another wire. Thank you.
Yeah.
We're gonna see if this one's long enough. It may not be. So the other thing about the Fathom is the standard Fathom that we use is 180. I'm sure most people use 180. If you want to do these long cases, you gotta get the longer Fathom wires. So there's inventory issues too, right? You don't want to stock 5 different types of wires that are all very similar. And so you have to think about, when you do these cases from the wrist, you really have to think about how much equipment you need, and if it makes sense to stock all this different stuff. But you do figure out what you like, and that's what you get. So I think we're probably still a little bit, when we did that run.
That's all the wire we got.
Yeah.
So,
So-
I guess we'll play with catheter a little bit.
Bell, let me get the 200 length
Yeah,
014.
I don't think.
So this is a
wire's
much
gonna work.
easier cannulation, I think, from the pedal. This is always the
That's-
case, I think,
It
with
is.
these.
And I would say that if you went distal to it, Aaron, you can swing that on the right wall and then just pull back and probably hook it. I think then you know you won't be on the posterior wall.
Yeah, we may actually even do a different view because we're seeing that overlap with that, the vessel, you know, these other vessels that we're not interested in. Yeah, let's
And
get that.
does that base catheter spin at all or no?
Oh, it does. So
That might also
you could
help
put
you
that
here,
down
too.
naked. Yeah, so we put that down naked in some cases, but I like to put it through the sheath because then I have the ability to torque it pretty easily. And I was doing that before. I'll show you in a second. We can actually move the base catheter. But again, the base catheter that high up is not that helpful as compared
Not at
to
all.
if we were doing femoral, we would put it right next to this. We could
Yeah.
probably even almost use the base catheter to cannulate this vessel in some cases.
If you spin this base just a little bit while you puff the micro, I think you'll get right to the origin. I think that'll be.
All right, so I'm going to do another little view here.
Oh, I see the origin.
You see?
It's totally was Sonny was saying.
Yeah.
We gotta hug it this way and then it'll
Yeah.
go in.
That's a good view.
Yep.
Have you used this catheter?
You know, I've
You
not
asking
used that
Sonny?
catheter.
Yeah.
and After seeing it today, I like it. I think the ability.
Yeah,
for
it's
you
pretty
guys-
good.
And it appears to be incredibly soft the way it tracked into that.
It's very soft.
It
It
is.
behaves. It's similar to the True Select. It's a little different, and obviously the shape is different. The shapes are, you know, these are sort of unique shapes that are very popular in Asia, but not so much in the U.S.
Here, you're free.
Where's our catheter? All right, there we go.
So I think I need a pointer, but hug it. See how it comes? So hug it up here. Yeah, and then keep going on yellow. Yep.
Woohoo!
Yeah, but
Oh.
you know,
Aw,
this is an 014 wire, so as Sonny was saying,
you gotta track it out a little
we
more.
gotta see how much wire we can get. It's about as much as I can get, and I'm gonna try to put it into the
Hub it,
origin and then let the
and-
catheter
yeah.
do the rest of the work.
Yeah, when that micro's at the origin, we'll see how much support it can give you to get more wire up. Yeah. I mean, I always say when I'm doing these cases, Aaron, is that it's so easy. You do it 3 or 4 times.
Yeah, I mean,
Like
we see where it is. It's just this
the
is
story
a
of my life. This is
Yeah.
this is the challenge. And honestly, this is the thing about GAE that, you know, I've always run into this challenge of like, okay, if you go femoral and you're coming from above, you have these angles that are the opposite way. If you go pedal, some of the ways are the opposite way. It's just, I think there's no one size fits all. So this is great to see. I mean,
So one of the things that I'm noticing with this base catheter, since it's 4 French, and again it's
starting to
subtle, but
gum up.
there's a fair amount of friction. Yeah.
Because it's single eyed, yeah.
So you know, this is one of the reasons why I like to use like a bigger, more robust base catheter. And this is definitely an equipment limitation. Try to get closer.
Yeah, see where it goes from there. Yeah, it looks
And
good.
There you
now
go.
that we're there, we might be able to get a little more wire.
Yeah.
Whoa,
Love
nice.
Careful.
We'll see. Don't say it yet.
Careful.
Trying to settle it all, settle this, make it a little
Is that
less.
That's a fathom wire again.
tense. Yeah, but it's the Fathom 14, not my fave. What do you think?
I
Not
like it.
I
bad.
think
Pull in
it's
a
not
little
bad.
more.
I'm going to give you some
There you
bad
go.
news that when you go around here, that's where you want to be. But yeah, you have enough length, you think, to get around there?
Oh yeah.
Looks like
We're
Yeah.
gonna start here. Can you
All right.
fluoro save that?
it. Great.
Great
Take that
job.
wire out.
Great.
That's a real challenge. It's a great job.
Fun part.
So now you'll do
Well-
this. You go back to a relative AP or a mild LAO.
Yeah,
in
that's
order-
exactly what I'm doing. We think alike, Sonny.
So do we. So
Yeah.
do we. Can I give this
But
to
you know, I don't
I like how-
like how far up that catheter is.
My favorite part
It's
about
just-
this case, two people who don't routinely scrub together, having to scrub together, because we run into this all the time. The best. That's
We
great.
used to be together a lot more. That looks awesome. Do you want to see a little more lateral?
In terms of positioning, well, we have some nitro, right, Chloe?
Mhm.
In terms of positioning in our microcatheter, would you go more distal here? Or would you just stop here?
So, okay, so if on the native, if you can just play that, can you guys play that and just take away the subtract? All of this is synovium in the
case.
sense that the superior lateral joint pouch does go that high. There's a recess, right, that goes that high. And that's actually what typically fills with blood when people get hemarthrosis. So I think it's the recess or pouch, superior lateral pouch of the synovial cavity. I think it's fine to embolize from here. You know,
Nitro?
if you just had
Yeah.
joint line pain alone, I would say, Aaron, you could go into the bottom of those two trunks, like right where you're at that bifurcation. But
Yeah,
I
but you
think
can
where
see a
you
lot of
are-
that stuff north is pretty abnormal looking. I agree.
Yeah, I think this is the nice thing about particulate embolization is you're going to allow the flow to just take it to the areas that are most hypervascular, and I think you're in a good spot.
Okay, so we have about what is this, 5-6 centimeters out, so we're still pretty good in terms of length of catheters. I think that, one of the points I wanted to make with this case is that it's not about the microcatheter length, because we do have long microcatheters now. It's really the base catheter length, and base catheters in different shapes. I'm gonna do a run here.
I like that.
And so that's really the limitation with radial access is the base catheter, not really the microcatheter so much. That looks really good.
Yeah,
Here,
Looks great.
let's-
definitely see some.
We're gonna go 1 cc at a time. Probably get maybe a cc and a half is my guess, but we'll
Can I
see.
flush that?
Yeah.
Sonny, are there any concerns that you have with the proximal embo versus a distal that you can comment on?
You know, here, the only thing is that you'll get a little bit more, if you were distal in that lower trunk and then beyond a couple cutaneous branches, you'd probably spare some cutaneous supply. I would say the danger of being very proximal in geniculars is really going into branches that go within the joint, like the middle genicular artery, potentially, dominant supplies to tibial
Starting to
nerve,
come out.
which are really at the origin. I'd expect they'd get a CC in here, and it'll be good to get a post run after a CC and see what that looks like. How'd you mix the
So
beats, guys?
we just did, I think, 8 cc's of contrast, and we didn't decant it. Did you decant it? I didn't decant it.
Chloe mixed them.
Yeah,
Did not decant it.
yeah, we don't decant. Do you decant?
I don't,
I don't-
well, I don't like to, but some of my
These
staff
are beads
will.
or, do
Beats.
you want me to keep
I'll
going?
get it to that same dilution of beads to contrast. Yeah.
They're very dilute, and I was always taught when I was a trainee, the better embolizations are the most dilute embolizations, and I think
Yeah.
that makes sense. It makes sense for tumors. It makes sense for this.
Can I flush after this?
What do you?
Yeah, I think
well,
flushed-
I have like a
flushed that
CC,
through.
CC and a
Yeah.
half. Yeah.
I tend to be under
let's
like
get a 1
Saline,
cc
please?
flush.
aliquots and then try and do aliquots and do a quick run in
Hold on.
between.
You want a CC and a half?
This is a 1 cc flush.
Thank you.
How much have you given already?
This is about a cc and a half minus the dead space.
Okay.
Looks great.
Sonny,
This is
do
a
you have an
much better
endpoint?
vessel. I like this vessel better than the other one, right, Simon? Maybe,
There's-
maybe. What do you guys think? A little more, or would you do a run?
Let's
Do a
do
little
run.
run. Do just a CC
Saline.
and see what it looks like. Yeah. I think it's going to look great,
Just a-
though.
like
I don't
a-
think.
Like a soft run.
Yep. I don't think you'll need more.
I think we could do a little more.
Yeah, I mean, maybe a touch. I
think?
think that.
Yeah.
Here's the thing, Aaron, is you have your patent antegrade flow, but if you compare that to your pre, I'm so big in this camera. Talk about losing 10.
You don't see the pruning.
I can't
Is
get my
that-
posture right.
You don't have that
Give a little
blush that
more.
your last run, if you just look at it, you had so much blush, and that's all
Yeah.
gone. I mean,
Yeah.
this is kind of like a debatable, and we always say, would you like to give it dusting, a little more?
So I know from my conversations with you that you're more of a light embolization guy. I'm a little
In the
heavier
knees.
Are you now?
in the knees. Oh, anywhere really.
Yeah.
So we gave half a CC
So Dr. Garcia gave another half, and now she's flushing.
Just want a happy medium between you two.
Sonny, when you do these cases for
Okay, we're flushed.
hemarthrosis, what are you using the same
Like
particles?
0.7.
I'll use a
That's
larger,
good.
typically use
Contrast.
something in the 3 to 5 range.
Okay.
And the target vessels are usually superior lateral, superior medial, and DGO. Yeah.
Okay.
As the main targets for post knee replacement hemarthrosis. That looks great.
More. I'm going to do a little more.
All right. All right.
You sound disappointed, but these are very dilute beads, so it's.
I think it's, yeah. I think it's great.
I think they were a little bit more dilute than
Yeah.
They're very dilute.
Aaron had said before. They were mixed to like almost 20. So
Okay.
okay.
As you guys are doing,
One more.
what's the plan for the current? Are you guys just going to float that down out the wire?
Yeah, so I think we'll try to float it because we also have a longer microcatheter we could use if we want.
Yeah. I think you'll reach. It looked like you were just.
I think we'll reach, but I would like to get it a little further in than just the origin, just because it's off the tibial. So, yeah, I think I'm going to try the other one, just so you guys can see a different catheter. But this is a catheter that we very rarely use. It's on the shelf, and it was about to expire, so I figured we should try it. It's a 175 True Select, which is, as I said before, it's my favorite catheter for prostate these days, but not in that length.
Okay, that's an extra.
But it does float a little differently than the one we're using. They both act very similarly, but I think we'll just sort of demonstrate it maybe without the wire. That looks so much better. I'm happier with that. That's more of an endpoint that I feel comfortable with.
That's good. Honestly, it was
More on the heavy side.
Okay.
He wants to go back.
The micro.
Yeah, we can take that out, and then we're gonna just put up another quick roadmap, and then we're gonna float this 175 down, like you said, and see if we can get it to go without a wire.
Put it back in.
Aaron, do you find that you can get a good roadmap sometimes with the micro, with this size, or is it challenging?
It's challenging. You can, but I'm more of a base catheter roadmap guy.
Yeah.
I like to see what I'm doing, you know?
Totally.
These were designed to do really good injections and even power injections that are high quality.
Yeah.
So, but it's just one of the, the microcatheter technology that we have. I was going to do a quick run, but that's okay. No, let's just do a quick run. The microcatheter technology that we have now is pretty impressive.
You guys going to go more of an LAO here?
Yep, we're just about to set that up. A little steeper maybe. Yeah, that's good. Because we saw it really, really nicely before. And we were sort of right in the origin too, but we didn't really get too distal. Okay. That looks like a really nice vessel for pedal, huh? I bet your wire goes into that without even trying from the pedal.
Everything does.
Okay.
So on that recurrent, oftentimes there's a bifurcation right after its origin into a deep and superficial branch. And I think you oftentimes don't need to be too high in it. My only concern whenever embolizing that is replicating the pressure of my injection so I don't inject too hard and embolic flows down the AT. That's the one thing that certainly can happen with recurrence. Is preferential flow can change and it'll go down the AT. Yeah.
Look at that.
So beautiful. So beautiful.
Let me store
So
that.
we're going to store fluoro because I thought that was cool, but that was what I wanted to demonstrate. So if you put the wire through the majority of the catheter, but you leave maybe about an inch out or back into the catheter, it has the ability to torque, but it also gives you see this wire is way too short, right? It gives you the ability to do what we just did. So I'm going to see if I can get the wire to come out a little bit just to get a little further. But that's, sometimes that's the best way to do it.
That was pretty slick.
This catheter is pretty impressive.
Yeah, it is.
the way this catheter tracks, even over the soft part of the wire, as you can see, is amazing. Okay.
Yeah. Yeah.
Did that microcatheter suddenly grow to be 225 centimeters?
Well, you were saying we couldn't do this from the wrist, so I figured I had to show you how to do it.
Challenge accepted.
There we
Thanks,
go. I love it.
Let's see where we're at. This, at least on the initial angio, looked like it was pretty significant. Yeah, you can already see.
Yeah.
So let's talk a little bit about location. Is this a good spot? I mean, we're going to give nitro here because we're already pretty distal in it, but
I think
would you
I
go a
think
little
it's
further or
good.
no?
The only thing I'd say is, can you play your last run, Aaron, one more time? Is that when
previous
this
one?
trunk? Yeah. Do you mind? So here, you see how that branch is fairly big up to there. And then on the next couple frames, I think it gets fairly small. I'd actually really want to be a little bit more proximal just to make sure I'm not missing both. Like, see,
Okay.
the recurrent has two trunks, and you might only be feeling, the front half of or the anterior aspect of the lateral
Yeah.
tibial plateau.
Yeah.
So, although you did demonstrate you could put that from the wrist to the knee to the brain, I think it'd be nice to pull a little bit.
I agree. I think, and we're reflexing a lot.
All right,
Yeah.
so
Also
what I'm
like
going to do, I'm going to just
But it-
line it up a little bit differently, and I'll pull back a tiny bit, and we'll just repeat that run. We just
Yeah.
gave about 200 of nitro.
Hold on a second.
Okay. Just going to puff back a little bit. There's those branches going down. I don't see any other branches
There
there.
you go. Yeah, you see how big
there's
that is
one.
now? Yeah, like even
Yeah.
just you pulling, I think you got. That looks like a good spot.
Yeah, I
You
think
have
so.
good antegrade flow. I think it looks, and you backfilled on your run. You'll probably see it here again, but you backfilled your inferior lateral pretty well. Got
That looks
infill
great.
right. Yeah, there it is. There's your inferior lateral.
Nitro.
We keep it separate.
I gave the nitro already.
There
Let's
you
do
go.
some embo.
Wow. You didn't even see it.
There you go.
Thanks. That was
Alright,
like
go.
you again.
AP.
Yeah.
Oh, slow.
Yep.
That looks good.
Nice.
You can see it going all the way into that joint.
Yeah.
Beautiful.
A-
So her
and the way
WOMAC was 53. What do you think? What do you think if you have a patient like this? What's your typical response? And tell me what you guys do in your practice to follow them.
So I would say I would tell a patient there's about a 70% overall improvement of your pain and disability score from baseline. But while there are patients who might get significantly better or mildly worse results, the
Wanna
average
flush, Aaron?
result in terms
Wanna
of
flush?
Yeah.
from baseline to new is about 70%. We follow them with your typical post-op, 3-day, 1 to 3 day phone follow-up, make sure they're doing okay. And then we see every patient at a month. And in a month, they do their scales again to assess what their pain is like. If they're a hemarthrosis patient, a little bit differently, but if they are like this type of patient, OA patient, it'll be a month, and then 3 months is where we would expect them to be at their new baseline.
New base. Yeah. Yeah, that's generally what we do as well. I think given what we've seen so far, I think she's going to do really well. Now, in terms of hemarthrosis, which we do as well, I'm typically using like 400 micron, around that range, like you said, 3 to 5. I've used 500. This is obviously, we've gone back and forth between different sizes, but I think 200 is sort of the sweet spot for me for this. The thing I wanted to ask you is, what do you think the role of resorbable beads? I know you've done some work on that, but resorbable embolics for this type of procedure, because we always sort of talk about whether we want to repeat it or not, and whether it's durable and all of that. So, what do you think?
I think
You want to do more?
I
they
don't think we need
certainly
more.
will have a role. In our practice, 50% of our genicular embolization is done with imipenem, and 50% is done with 200 micron beads. We are looking at these results right now for publication to see what the difference is. Anecdotally, I can tell you we don't really see much of a difference.
We're
I will
flushed.
tell you that the post-op, however, is significantly less discomfort, skin discoloration, or even tightness in the knee with a resorbable, or at least a rapid resorbable, like imipenem. But
Yeah.
durability, I've yet to know. I don't know, what are your thoughts on resorbables too?
Well, I think for this it makes sense. This procedure. There's not a lot of procedures that I do where I think that they would be. I like permanent embolics for prostate, obviously. But this is, I think, a good application for it, and I think it definitely needs to be studied. How hard is it to get imipenem in your lab?
You want to do more? Can you
A
do
little
it
more?
higher?
Well, before we talk about that, what do you guys think of this angio? Should we do a little bit more? I mean, I'm sort of right at the point where I think we could probably stop in this vessel, but there's a little. I think there's Simon. Do you think there's a little vascularity there?
Yeah, a little on the inferior aspect.
Yeah, maybe a little bit.
Can you put the previous one up?
Yeah.
It's a good answer from the PGY6.
I
I
would stop.
so, to Simon's point, there's a little bit of vascularity there in the bottom aspect, but the other thing nice here is you're no longer filling that collateral across from the inferior lateral that
Yeah.
swings all the way over to the inferior medium. So, I think it looks great. I was gonna say real quick, one thing that you guys demonstrated really well on this that I'm always trying to explain to people is look how far your catheter comes from the popliteal artery posteriorly all the way to the front of the knee. Because this knee must be turned all the way out or something. Like I bet the foot is
she turned her knee. Yeah.
yeah, and
Yeah.
so it's impressive because this is what happens on the superior lateral, on all of the genicular arteries, is that they all wrap around from back to front.
I think we're gonna probably stop.
Yeah, the way it was flowing, I would
Yeah.
probably stop.
So we're gonna take this microcatheter out, and we'll just do one quick angio, and I think we're done.
I'm gonna let you do the honors.
Let's just.
Chloe, let's let Simon do the honors. Here you go.
Sonny, while they're doing that, are you doing any genicular nerve ablations?
So we're not anymore. I was for a while, and I found the results at least just so variable. Jet. And I think while it works, it's fairly uncomfortable for the patient to, give local over such a large area of tissue, and then, as you know, you're really just you're trying to ablate
That looks good, right?
this lengthy area and hope to catch the nerve. What's been your guys' experience, or are you guys doing it currently? Any nerve ablation?
We have not done nerve ablation. At least I have not done. Jay, I think maybe you did it when you were out in California.
Yeah,
Is that right?
I used to do them frequently actually at MI.
Yeah, I didn't do any genicular
Yeah.
nerve ablations. I was looking into it, but I did some genicular embos, but decided that was I trusted it more, just conceptually.
Yeah.
Dr. Garcia has some experience when she was at
I
Emory.
agree with everything you were saying, Sonny. Although pretty straightforward.
The only other thing that I see here is maybe that middle geniculate blush, but as we were talking about before, we've really devascularized that whole area on the lateral part of the knee.
Shall we compare it to the original?
Yeah.
Yeah, we can.
See the original.
Yeah.
It's like night and day.
Much different.
It's great. Looks amazing.
I think it's time to stop.
So can I get a TR band large, please?
9:59. That was.
Yeah.
Wow.
So we have a long sheath. I'm just going to show you guys quickly, the technique for removing the sheath. We'll take the glide wire advantage. We'll put that through. We'll just leave that, and we'll pull everything out together as a unit. It's a little different than when we have a long sheath than when you have a short sheath.
Thanks.
Because as a general rule, we take all of our radial catheters out over wires. We don't pull sheaths or catheters without a wire. We don't like to use the microcatheter as the wire because the microcatheter obviously has embolic material or could have embolic material in it. And so people always talk about how to avoid complications with radial access. This is, I think, an important tip. You don't want to take catheters out across the vertebral.
Can I bring you down a little bit for the camera?
All right, there we go. Okay, so that's that. Now, once the wire's in, we're going to basically put the TR band on, and then we'll pull everything together.
Sorry, I'm just getting you in the view. Okay.
Okay.
You have your TR band?
Yeah.
Aaron, why do you I haven't done this before, so I'm curious. I understand why you pull the catheter with a wire. Why do you put the TR band on now as opposed to after the base catheter is removed?
Well, we're going to take everything out together as a unit. That's the only reason.
Ah.
So I'm just going to pull it
Don't
all
forget that.
together because we're not going to fluoro at this point. And so this is
Oh, I
you
see.
guys can see the access site here. This is her thumb. So she's, we're about, what is that, 15 centimeters above the styloid?
Yep.
Yeah.
You let me know when you're ready.
And when you do high punctures, you generally want to use a little bit more air.
How much do you have in there?
That was 18.
Ready?
So we're going to take the whole thing out. It's nice and hydrophilic. This is a beautiful sheath. Super, super easy to use. And it really allows us to do not only this, but peripherals and legs as well. Nice pulse. I actually don't even know. So if Kirema can compress the ulnar, I'm just going to feel the pulse here. We may not even need to take any air out of it. Oh, she's got a little bit of a, you can see a little bleeding. So that was about 15 cc's total. And so this is the way that we're going to let her recover 1 hour. Beautiful. She'll go home very quickly. Any other comments, Jay or Sonny?
Really impressive that you guys were able to do that. And I think utilizing that micro with that shape really was advantageous. Like you said, having the right tools, key. And I agree, Aaron, to what you said earlier about the limitation of the length of the base catheter. Really that sweet
Yeah.
spot of 40 to 150 is kind of where you're looking. Yeah.
Yeah, that is the limitation. So, this is a case where you could do it, but not every case is like this. And so clearly pedal access and femoral access are not going away anytime soon for this procedure. And it may, in many cases, it may be preferable. But I really appreciate everybody's comments and thank you for your attention. And hopefully this was educational for everyone.